Welcome to the Deep Dive, where we take clinical sources on these really complex subjects and we basically extract the vital knowledge. We give you the blueprint for being instantly well-informed.
And our focus today is on something that seems deceptively simple, the conventional radiograph.
The humble X-ray.
Exactly, and specifically how it's used to evaluate, a suspected bone lesion.
Right, so the mission today isn't to just wait around for the MRI or the biopsy. It's really to drive home that the initial X-ray is the most important diagnostic tool you have. We're grabbing the diagnostic decoder ring, and we're going to systematically analyze 7 specific visual characteristics.
And you combine those with 2 crucial patient factors, age and location.
And that whole package predicts the lesion's entire story and dictates how you manage it.
And that story has incredibly high stakes. I mean, the vast majority of bone lesions are benign, non-ossifying fibroma, simple cysts, things that might just need observation.
Okay.
But we have to be immediately and, frankly, ruthlessly efficient at spotting the rare, aggressive ones. The primary malignancies like osteosarcoma, chondrosarcoma, and Ewing sarcoma. The X-ray is the necessary first step. It's the optimal way to assess the internal biology and predict just how aggressive it is.
Okay, let's unpack this. So before we even zoom in on the spot on the bone, you said we need 2 clinical filters. Context is king.
Always.
Let's start with the most important one. Patient age.
Absolutely. Age instantly eliminates, probably half of your possibilities right off the bat. If the patient is younger than 30 years old, you're worried about tumors that are associated with skeletal growth and development.
Okay, so what does that mean? Malignant versus benign.
So the common malignant concerns are Ewing sarcoma and osteosarcoma. And then the common benign lesions in that young group, things like simple bone cysts or SBCs and non-ossifying fibromas, NOFs.
And this is where it gets really interesting, because the second the patient crosses that threshold into adulthood, say over 30,
right,
the biological clock just seems to shift what tumors are likely to show up.
The whole list flips. I mean, it flips entirely. In patients older than 30, the overwhelming majority of malignancies are not primary bone tumors. They're metastases.
From a cancer somewhere else?
Exactly. Or multiple myeloma, or chondrosarcoma. And the benign lesions shift too. We start seeing giant cell tumors, GCTs, and Paget disease, which is exceedingly rare in younger patients. You can often cut your differential list in half just by looking at the date of birth.
That is a really powerful filter. So the second filter is location, where the lesion is sitting in the skeleton. And I always found it fascinating that, almost every type of tumor seems to congregate around 2 specific areas.
Yeah.
The humerus and the knee.
They are definite bone tumor hotspots, yeah. But if you look beyond that general hotspot, specific locations are highly, highly suggestive. So if you see a lesion in the spine, the rule is always to think metastases, multiple myeloma, or maybe an osteoblastoma.
And what about, say, the hands or feet?
Small bones of the hands or feet. That points really strongly toward an enchondroma. And a dark lesion in the skull, often eosinophilic granuloma.
I get the general location, but the sources we looked at really emphasize that when you're dealing with long bones, like the femur or the tibia, you have to get almost surgical with your geography. You have to specify both the longitudinal and the transverse location. Why is that precision so critical? Is there, a biological reason a tumor picks the shaft over the end of the bone?
That's a great question. And it often comes down to the origin of the cells and, the blood supply during development. So these spatial categories are just essential. Longitudinally, we divide the bone into 3 parts.
Okay.
You've got the epiphysis, the end caps. That's mainly for GCT and chondroblastoma.
Yeah.
Then the metaphysis, the wider part where the growth plate used to be. That's a common site for osteosarcoma and ABCs.
And the middle.
The diaphysis, the shaft. That's where you'll find Ewing sarcoma or fibrous dysplasia.
So just to recap, epiphysis is home to GCTs, metaphysis is for osteosarcomas, and the diaphysis is Ewing sarcoma territory. That creates a very clean list.
It does. And then you have to think transversely. So where is it sitting within the bone mass? Is it truly central, or is it kind of pushing against the edge?
So what are the categories there?
You've got intramedullary central right in the middle. Yeah. Think simple bone cysts and chondromas. Then intramedullary eccentric, which is pushed off to one side. That's more like osteosarcoma or GCT.
And inside the hard part, the cortex.
Right. intracortical, lodged right within the thick cortex itself, often an osteoid osteoma. And finally, juxtacortical or surface, which is just sitting on the outside surface of the bone, like a surface osteosarcoma.
That is a perfect transition. So we've placed the lesion on the map based on age and geography. Now we finally get to zoom in on the picture itself. What's the very first visual cue we should be looking for?
We start with density. Density tells us what the lesion is doing to the bone. Is it destroying it? Is it building new abnormal bone? Or is it doing both?
Okay, and we have 3 categories here, starting with sclerotic lesions.
Sclerotic lesions are dense, white, bone-forming. They indicate a productive process. So examples would be osteoblastic metastases, often from prostate or breast cancer, or a harmless osteoma, or even a healed, non-ossifying fibroma.
And then the opposite of that are lytic lesions, the ones that destroy bone. They appear lucent or dark on the X-ray.
Right.
Now, if it's destroying bone, that just seems inherently aggressive. Is that always true?
Well, that's the critical distinction. A purely lytic lesion is certainly alarming, but its aggressiveness depends entirely on how it's destroying the bone. We'll get to that when we talked about margins.
All right.
But yes, lytic lesions are the ones we scrutinize the most. The sources mention this fantastic mnemonic for thinking through olytic lesions, especially those with, well-defined margins. It's phegnomashic.
Phegnomashic. That is a brilliant tool, but it's a mouthful. So if I'm looking at a lymphatic lesion with those nice clean borders, what does the rest of it point me toward? We heard F, E, and G.
Let's just run through a few more, because this is where a well-trained eye really shines. F is fibrous dysplasia. E is enchondroma, or eosinophilic granuloma. G is giant cell tumor. N, non-ossifying fibroma. O is osteoblastoma.
Do I keep going?
M is multiple myeloma, though that's often permutive. A is aneurysmal bone cyst. S is solitary bone cyst. And H, I, C cover things like hyperparathyroidism, infection, and chondroblastoma. It just gives you this really comprehensive mental checklist.
Got it. And the third type of density is just mixed, a combination of the two.
Yep. Mixed density lesions show both destructional lytic and formation sclerotic at the same time. You should think of processes like Paget disease, fibrous dysplasia, or metastases from certain aggressive cancers like breast or lung.
All right, so moving on from just the general density, let's talk about matrix or mineralization. This is maybe the biggest clue about the tumor's origin because it shows what kind of tissue the tumor cells are actually producing.
That's correct. Matrix analysis tells us if the tumor is bone-forming, cartilaginous, or fibrous. If you see an osteoid matrix, it indicates a bone-forming tumor.
And what does that look like?
Visually, it's fluffy, amorphous, kind of cloud-like, dense mineralization just floating within the lesion. This is the signature of aggressive bone tumors like osteosarcomas, or benign ones like an osteoid osteoma.
Then we have the chondroid matrix, which sounds much more visually distinct.
It is. It's the key to identifying cartilaginous tumors like enchondroma or chondrosarcoma. The mineralization pattern is described as flocculent, arc-like, or ring-like. I often tell students to look for something that resembles scattered popcorn kernels inside the bone.
Popcorn kernels.
That pattern is almost pathognomonic for cartilage.
And the third type, ground glass matrix. The source calls it hazy or frosted. That's our signature for fibrous dysplasia, isn't it?
Exactly. It's subtle but distinct. The bone structure looks hazy, like looking through frosted glass. And finally, if there is no visible matrix, just pure lucency, the tumor hasn't produced any recognizable calcification. That often points toward metastases, lymphoma, or Ewing sarcoma.
Okay, so we've analyzed the substance and the tissue type. Now we need to determine its behavior. And nothing predicts behavior better than the next 2 findings. Margins and periosteal reaction.
This is it.
This is the difference between a patient who can wait 6 months for a follow-up and one who needs to be in the oncology suite tomorrow.
Precisely. The margins and the width of the zone of transition, that's the area between the lesion and healthy bone, are the key indicators of growth speed. We quantify this aggression using the Lodwick classification.
Okay, let's walk through that aggression scale, starting with the least worrying one.
Type I is geographic. It indicates slow growth, meaning the host bone has had time to react and sort of contain the process.
And there are some types.
Right. Type IA is the least aggressive, a
Okay.
well-defined lesion surrounded by a clear sclerotic rim. That rim means the bone had time to lay down a protective fence. Classic examples are simple bone cysts and NOFs. Type IB is still well-defined, but it lacks that sclerotic rim, so this is indeterminate. It's often seen in a giant cell tumor or maybe a very low-grade chondrosarcoma. It's definitely concerning, but it's not a clear emergency yet.
But then we get to type IC. This is where we enter that zone of transition, where slow growth gives way to high speed.
That's right. With IC, the border becomes ill-defined and the zone of transition widens significantly. This blurring is a huge red flag for aggressive growth. You commonly see it in high-grade chondrosarcoma, osteosarcoma, or fast-moving metastases. The tumor is winning the race against the host bone.
And the final two types, moth-eaten and permutive, they sound truly frightening.
They are the immediate alerts. Type 2 is moth-eaten. It's characterized by multiple small, ragged holes, like an old garment eaten by bugs. Type 3 is permutive, which features these tiny, diffuse, ill-defined destructive areas that resemble infiltration.
And those mean what?
These patterns signal highly aggressive, fast-growing malignancies. Ewing sarcoma, multiple myeloma, osteosarcoma. The tumor is spreading faster than the eye can even focus.
Which leads us right into the periosteel reaction. This is the bone actively trying to fight back against that invasion. This is where the images get visually dramatic.
It is the immune system's last stand, right there on the X-ray. And the appearance of the reaction tells you the speed of the insult. So non-aggressive reactions happen when the process is slow. The bone has time to organize the repair.
So it looks solid.
It results in solid, continuous, often thick layers. A dense, solid reaction is characteristic of an osteoid osteoma.
But those aggressive interrupted patterns, like the sunbursts, that's the bone signaling, it just can't keep up, right?
Exactly. Aggressive reactions caused by fast-growing malignancies or severe infections show these disrupted or spiky patterns. You have lamellated or onion skin, where you see multiple concentric layers. That suggests intermittent or rapid growth.
Common in sarcomas.
Sarcomas or osteomyelitis, yep. Then there's perpendicular or hair on end, where fine lines of new bone grow perpendicular to the cortex, a classic sign of Ewing sarcoma or osteosarcoma.
Yeah, most famous one.
The divergent or sunburst pattern, this pattern, like rays of the sun shooting out, it just screams osteosarcoma. And finally, the Codman triangle. This is an elevated, acutely interrupted wedge of periosteum lifted away from the cortex, typically seen with highly aggressive processes like osteosarcoma, metastases, or deep infections.
So if you see that sunburst pattern or Codman triangle, you don't even need an MRI to know this is an emergency. The X-ray has already told you.
It has provided the behavioral diagnosis, yes. It dictates immediate referral. And we have 2 final imaging findings to round out the 7.
What are those?
Cortical involvement and soft tissue mass. So if the process is slow, it causes endosteal scalloping erosion of the inner surface or expansile remodeling, where the bone kind of balloons outward without breaking. But aggressive, fast processes cause outright cortical destruction. You see holes just blown through that protective layer.
A classic sign of high-grade malignancy.
It is. And the soft tissue mass, that's the tumor growing outside the bone.
Which means it's broken contained.
Correct. The presence of a soft tissue mass is highly suggestive of malignancy Ewing, osteosarcoma, lymphoma. It shows the tumor has broken its shell and is now invading surrounding muscle and fat.
Okay, now that we know all the signs of a true tumor, we have to address the traps, the mimics. For anyone learning this, awareness of these is so crucial. These are non-tumors that look terrifyingly aggressive.
And avoiding that misdiagnosis is paramount. It prevents unnecessary anxiety and, more importantly, unnecessary biopsy. Some are just normal anatomic variants, like a humeral pseudocyst.
What's that?
It's just a loosened area in the upper arm that's often mistaken for a metastatic lesion, but it's just a normal dip in the bone's architecture.
And what about something like trauma? Stress fractures. They can look surprisingly nasty, can't they?
They really can. A simple stress fracture can generate this floated, aggressive-looking periosteel reaction that mimics a high-grade sarcoma. You also have developmental mimics, like the cortical desmoid, a benign, self-limiting irregularity that can look like a suspicious tumor erosion.
And infections often look like tumors. I'm thinking of the Brody abscess.
A Brody abscess, yeah, a chronic form of osteomyelitis. It causes a lytic destruction and can mimic an aggressive osteosarcoma, especially because it generates its own unique periosteel reactions. And then you have metabolic mimics like chronic tophaceous gout, which causes erosions that look exactly like aggressive bone tumors.
Which is why you have to combine everything.
You have to. All 9 factors, age, location, and the 7 radiographic features before you settle on a diagnosis.
So how do radiologists bring all of this highly visual, very detailed information together into a structured, actionable plan? We started by talking about the X-ray as the primary blueprint. The final piece of that is the ACR Bone-RADS V2023 system.
Bone-RADS is the systematic culmination of all this decoding. It's a risk stratification tool that assigns points based on how many aggressive features you've found. It quantifies the risk to guide management. It removes the guesswork.
I notice that not all 7 features are weighted equally, so which findings trigger the most severe scoring?
The system assigns the highest point values to the features that indicate rapid, aggressive growth. So, for instance, aggressive margins, Lodwick type 2 or 3, the moth-eaten or permeative, that scores the maximum, 7 points.
7 points, just for that. What?
Just for that. The presence of a soft tissue mass scores 4 points. Any aggressive periosteal reaction, like a Codman triangle or a sunburst pattern, that also scores 4 points. And a known history of malignancy automatically adds 2 points.
So you add up the score based on the most aggressive findings you see, and that sum dictates the immediate next step for the patient. Which is why knowing the difference between a Lodwick IA and a Lodwick III is so critical.
Precisely. A very low score, say 1 to 2 points, typical for a slow-growing, non-ossifying fibroma. That just means observation or maybe annual surveillance. But once the score hits 5 or 6 points, you're in the intermediate risk category. That mandates an orthopedic oncology referral and advanced imaging, like an MRI.
And 7 or higher.
A score of 7 points or higher. That is high risk. That means immediate orthopedic oncology referral, a recommended biopsy, and staging with advanced imaging for a presumed metastasis, chondrosarcoma, or osteosarcoma.
The X-ray is literally the single most powerful tool in determining the entire clinical trajectory.
It is the primary blueprint. It contains vastly more information than just spotting an abnormality. It predicts the biology, it stratifies the risk, and it determines whether the patient is safely observed or rushed to the oncology suite.
It's just incredible to realize how much prognostic and diagnostic information is packed into that initial conventional radiograph. We started with what seems like a simple image, and by systematically applying these filters like age and location and decoding the tissue characteristics and aggressive patterns, we've unlocked a whole management strategy.
The key takeaway is realizing the X-ray is the foundation. It forces you to think biologically. You just can't afford to miss the signs that scream aggression.
We saw how characteristics like a Lodwick type 3 or that divergent sunburst periosteal reaction automatically trigger an aggressive score and an immediate referral. If these subtle visual findings have such profound instant management implications, it makes you wonder, what other simple, commonly dismissed visual cues in medicine, whether it's on a skin check, a blood smear, or a dental scan, do we routinely ignore that to an expert eye already tell the entire story?